Te hei mauri ora no ronga ki te whai au ki te ao marama ki a rātou mā haere atu rā. Ki rangi nui I ronga ki papatunu kua takato nei tēnā rā koroa no reira ki a tātou tipina Matua. Rātou ki a rātou haere atu rā. No kotorana ahau ko Clan Fraser Okuiwi ki te taha o toko papa ko te Clan Gordon, ki te taha o toko tipina wahine ko te Clan Glencoe MacDonald, ko Fraser Todd toko ingoa. E nei noho ana ahau kei wanganui atu waka a maui te teiti atu maunga. Taki timu tēnā rā koutou katoa. Thank you very much, and it's a real privilege to be chairing this session. What we're going to do, I think, as Jared mentioned, is we've got 5 speakers. The first 2 speakers appear. 10 minutes speaking, 10 minutes questions. Move on to the next speaker. They'll introduce their topics as they come up to speak. The speakers we have, Sue Bagshaw speaking second. Dr. Sue Bagshaw got a lot of experience as an innovator and clinician in primary care around alcohol and drugs. Teddy Huriwai, who most of you I'm sure will know, speaking third. Christie speaking fourth. But first and foremost, and probably the most important speakers today, we've got Kelly Pope and Leo Jr. Apaipo, who I can always think of as LJ, who are consumer advisors. So first of all, stick your hand up if any of you are under the age of 25. Excellent. Excellent. No, really. Under 22? Excellent, because we've been talking about them all day and haven't heard from them yet. So our first speakers, Kelly Pope and LJ, are going to give you perspective and from the voice of young people. And I think, as I said, I think that's the most important voices that we're going to hear today. Just bear in mind that it's often nervous in this kind of situation, so I'm understandable that you're nervous, but do try and support our speakers as best you can. Don't be too fearful of them. They'll just tell you what they want to tell you and make sure you listen. So first up, Kelly and LJ.
Hi everyone, kia ora tātou. It's really good to be here, and thank you to Rick and Gerard and Sarah and everyone who have invited us to come along. Can you hear me if me and LJ are sharing? Yeah? Kind of? Okay, that's good. Well, I'm going to go first for 5 minutes, and then LJ's going to take over and talk about his experience working with Mirror Services as a youth consumer advisor. My role is with the Werry Centre, also as a youth consumer advisor, and I've been asked to come along today to speak a wee bit about youth-friendly services, because that's essentially, I've taken a lot out of what has been discussed already, and it has focused a lot on youth-friendly services and the need for that already, which is great, and just, noticing some... Oh. Whatever that was. Just noticing some things that people have said. Peter said earlier in his opening that young people can find it difficult to engage with services that are labelled addictions or mental health or illness, just because of the stigma and the dauntingness of those labels. That's an aspect of being a youth-friendly service, is considering what we call ourselves to begin with. And also getting around the fact that some young people aren't help getters, as Christie said this morning as well, and that's an aspect of youth-friendly services as well. So I thought I'd just talk a little bit about my impression as a young person who's been through mental health services personally, about what youth-friendly might mean. And when I think about youth-friendly services, I always remember times that I've been asked to come in and help design waiting rooms, and it's a really important thing. Don't get me wrong, it's a really important thing. But I just wanted to try and get across that youth friendliness in terms of service delivery is about way more than physical space. It's about way more than comfy cushions and beanbags and bright paintings and waiting rooms. Physical layout of the building is really important. I talked to one young person when I was doing some research once, and she was talking about an adult service that she had to access, but she was 18, so she'd just hit that cut-off out of the youth world into the adult world, and she had to go to this community mental health service she described it like a rabbit warren. There were corridors everywhere. You had to take flights of stairs or elevators that you had to get swiped in for, and she said the place just made her feel crazy. She felt like it was an appropriate place to be as a crazy person, which is kind of amusing and also quite sad as well, because we need to be thinking about this, and I guess that's from a bigger planning level, where our services are, what they feel like for people coming into them, and that's where waiting rooms, office space, things like that youth advisors get called in to consult around, where that kind of stuff comes in as well. It was really good to hear earlier from people's talks, because my experience has been mainly in mental health and helping out mental health services, although the Werry Centre obviously straddles both mental health and addiction support and workforce development. But it's great to hear that the AOD sector's more into being out in the community, because then you get around those issues, around rabbit warrens for buildings and around unwelcoming waiting rooms and things like that. But that also means that that the meeting spaces that get used for appointments need to be appropriate as well, appropriate to young people, not just deemed appropriate to services. And it's really down to choice and about making sure that young people have empowered choices. Because if you say to someone who's 16 or 17, okay, so you live over this side of town, shall we meet at the local McDonald's? Chances are they're going to say yes, because if you're a service provider, there's that power imbalance, and you kind of, if you get something put to you and it's about your mental health, or it's about addressing some of the issues that are having a real impact on your life, you're probably just going to say yes to whatever. So making sure that we're putting it back in young people's courts all the time and saying open-ended things. Where would you like to meet? What suits you best? We can do things. We can be really flexible, because that's what I think young people need in a big way. So avoiding any kind of coercion or any kind of pressure to go one way or the other, and giving young people real choice is important. Youth-friendly methods of communication, another aspect of youth-friendliness. So some services have started doing things like e-texting and stuff like that, which is really cool to see. When I went through services, I'm almost 24, I'm 24 next week. And when I went through services for the first time, I was 14, so that's almost a decade ago now. And we just had letters come out to my home address, which was fine as it was, but if I was from a family that was a bit prying, or if I didn't get along well with my family and had open communication and stuff, I would probably find that quite uncomfortable. So it's great that there's more ways now that services can direct communication to young people themselves, since we are the centre of the care that's being provided. I think, and it's something that Tanya's heard a lot of lately, because it's kind of my thing at the moment. 1 minute? Cool. I've been on a wee bit about, thank you, about confidentiality and the importance of confidentiality in youth-friendly services, or in care that's going to be appropriate for young people. And I think that the telling young people we're not going to get anyone involved unless you're a threat to yourself or someone else, or someone's a threat to you, and then leaving it at that. Young people who are going through services probably feel quite often like they're a threat to themselves or someone else, or like they're possibly in danger. So leaving it at that is sometimes quite shuts down conversation before it can happen. So I think an aspect of youth-friendly services is having real decent conversations about confidentiality. What does it mean? Who will I involve? How will I talk to them? If I do have to break confidentiality, that is actually not the end of the world, and we can work around that together and come up with a plan together. I think that kind of thing makes it much easier for young people to trust. I'll just quickly, if I've got time, Fraser, I'll just quickly give a couple of examples of services that I think have tried to be youth-friendly and fallen down a little bit. There's a service set up in Christchurch, I think post-Quake, a youth office for work and income called the Youth Base, or Basebook. But from what I've heard talking to young people is that it's actually really not youth-friendly, even though it's called Basebook and it's got a flashy sign out the front and it's situated near the youth hub and things like that. because young people are still getting letters from Work and Income saying you have a work and income appointment, not a Facebook appointment. You have a work and income appointment, please come into our central office, and people show up in Sydenham. Not at this, or they drive up and down Barbados Street and can't find work and income and then go home. And don't have a number that they can call to get in touch with their case manager, because that's broader work and income policy stuff that gets in the way of communication and things. So that's one example. There was a youth directory that was published, which was great in a lot of respects, but for the specialist mental health services, a lot of language that I think would shut off young people even seeking help there to begin with, around we are a specialist mental health service for moderate to severe mental health issues. And I think a lot of young people would look inwards and think, oh well, my problems aren't that bad, because that's one of the biggest barriers to young people seeking support, is thinking, oh, I'm not that bad, other people need help more than me. So, and that's come through in research and things like that as well. So it's great to hear that AOD services try and get around that by going out in the community, by actively seeking engagement with young people. But just thinking about, if young people are ever in a position where we are flocking to AOD services and saying we do have problems, thinking now as well about the situation with synthetic cannabis being banned and all the possible stuff that's going to come along with that. Youth friendliness is about not gatekeeping, so making sure that we're always aiming to have as many young people seeing us as possible, wherever possible. And if they don't quite need our support or they need to go somewhere else, that's fine, and services can direct them and do some hand holding and some navigating and things like that to get them where they do need to be seen. But I think youth friendliness is services starting from a point of saying we want to see everyone. It's not an inconvenience for us if you show up and you have different issues or not very many issues or lots of issues. We're going to be there and we'll take the first steps with you. So I think that's important. One of the best ways of having youth-friendly services develop is through having active youth consumer participation. So I'm just going to pass over to LJ, who is the youth advisor with Mirror Services, and we'll talk a wee bit about that.
So Kelly's just going to sit down because I'm pretending to be a gatekeeper and I'm too wide so nobody's there behind me. Kia ora tātou katoa toa, talofa lava, maru e lei, halolo geta, nisa bole venaka, whakalofa lahi atu. Good afternoon and kia ora koutou katoa, welcome to our Indigenous peoples. I guess I would like to start my address by acknowledging Gerard for extending your invite, with Kelly acknowledging that it might be a good idea to have another youth consumer advisor to support her. So I thank you for extending your invite to me. I also want to acknowledge and thank Rachel for her organisation of my transport to and from Wellington and making sure that I was well looked after in getting here. So thank you, Rachel. Also Terry for your address this morning and welcoming everybody. Thank you very much. And Fraser also. Like Fraser said, he knows me generally as LJ. Fraser used to work very closely, still does, with Auntie Claire and my late uncle Takarangi, who also, some people may not be aware, actually helped name the service, Whakaata Tohu Tohu, Mirror Services, which I'm now the Youth Consumer Advisor for. So thank you very much to everybody I've acknowledged before me, and thank you for Kelly to passing on. So as a Youth Consumer Advisor for Mirror, I have been involved since I left school in 2010, mid-2010. I've been involved on and off since then. I've done a wee cameo up living in Taranaki in New Plymouth and worked for a catering company up there and then moved home and am now back with Mirror, among many other caps that I wear in the community. So I guess one thing to acknowledge would be that we, Mirror, are an NGO. We have had a Youth Consumer Advisor for the last 20 years, I believe, so since 1990. And we are not actually funded for a Youth Consumer Advisor, so my role is funded out of existing funds, and I'm on a contract, so I'm not a full-time employee, and I come in and I'm kind of like a whirlwind because I'm so busy everywhere else. I kind of just whiz in and whiz out, but we really do get some fantastic work done. So I was asked to speak about positive youth engagement And so I thought I would just discuss in my 5 minutes some things that I've done and how we operate at Mirror. So I'll tell you that. I have been involved in an array of events and formal occasions. Sorry, I've got a loud voice, so I'll probably scream through the microphone. I've been involved in mihi whakatau more recently. I've been involved in the whakawātea, as Deb said, of our new Youth Exemplary Service, in which I would like to acknowledge that we are very lucky to have a team leader, Tangi no Motu. And for me, that's really exciting, having Tangi leading the Youth Exemplary Service. As a young Pacific Islander, for many years there has been a large gap between my generation, my parents' generation, and the grandparents' generation, so my father's father and his parents. They don't understand the context of being a young Pacifica person who is being expected to speak mother tongue at home and then going into school, for want of a better word, dealing with a colonised, diluted version of education that does not value or respect Māori or Pacifica views. And so that's something that I really struggle with and my brother struggled with. So I think it's fantastic that we now have Tangi leading the Youth Exemplary Service in Dunedin. We have a large contingent. We have 3,000 people that are Pacific in the Otago Southern region. And so because of the contracts that Mirror has, we will be able to deal with most of those young people. What I find, sorry, I've already said that, is really exciting that I have the opportunity to work with Tangi alongside some of these Pacific Island students who are facing multiple issues with their families. So they're being expected to go to church, they're being expected to play sports, they're being expected to look after younger siblings. And so when some of those things don't happen, they're then being guilt-tripped by their parents or made to do what the parents think is necessary and ignore everything else. So education is often something that falls behind, and then of course when you don't go to school because you're looking after younger siblings, then the ministry comes after you and tells your parents off, and then in tow you get told off, and that's something that is really hard for us to deal with. And so when we don't have a lot of practitioners or psychologists or clinical people on the ground that can deal with young Pacific Islanders, it's actually really quite difficult because you can't grasp the concepts or the cultures. So some people might say, I've been to a Pacific training workshop and I am competent in dealing with Pacific people. Okay, I can understand and appreciate you might have gone to a Pacific cultural competency. However, within each different Pacific Island group, there are completely different competencies. So you might be competent in dealing with the basics of each one, but you may not necessarily be disciplined in each one specifically. So in my work, I've been involved in mihi whakatau and welcoming new staff, opening the Youth Exemplar Service. I'm invited often to board meetings, and I go and attend those. More recently, I've been attending the quality management team meetings, and we discuss all sorts of things from policy and procedure to issues that have been raised and that we need to deal with. What else do I do? So I'm involved in, sorry, I've got a whole lot of things going around in my head that I need to spout off. I'm involved in a number of training opportunities. So our staff at Mirror are very well versed in keeping up with the youth and what is, I guess, what do you call it? Cool and hip. My brother constantly tells me, how can you be a youth consumer advisor because you're not cool and you're not hip, and how do you know because you don't speak our lingo? I don't reply in text language because I don't understand it, and he thinks I'm too old. So our staff are very well versed in welcoming a young person into our service that is age appropriate. Our signage around the buildings on our sites is all very youth friendly and again age appropriate. We have a counsellor who works with young children specifically, and in her room she has a doll's house with some dolls in there, and then you see this amazing vintage wardrobe which is like The Lion, the Witch and the Wardrobe, and so kids go in there and that's an environment that they feel really safe and comfortable in, and no one's going to hurt them, so they're comfortable in dealing with the counsellors and the staff that we have in the building. Our reception staff treat any young person that walks into that service as they would a professional client that's coming to visit Deb, our director. So they would get a coffee, a tea. If we're offering muffins or biscuits that day, they would get that as any other person would. And something that I'm quite fortunate in, I sit in the Events and Community Development team at the Dunedin City Council, and so lots of people actually don't know that I am the Youth Consumer Advisor for Mirror, and so I get a good kick out of going places and hearing about how this young person has had a horrendous event or something happen in their lives. They've had to see a counsellor, didn't want to see a counsellor, thought it was a load of crap, what a waste of time. Went in and seen some of the team at Mirror and actually have enjoyed and has a positive engagement with youth counselling services. So to me, that just speaks testament to what we offer and how we work to ensure that we are providing a youth-friendly service. Without blowing trumpets, I would like to acknowledge Deb for the hard work that she does in ensuring that we have a team that really does work for the betterment of the young people and focusing on what they need as opposed to focusing on what they think the young person needs. So thank you, Deb, for selecting a great staffing team all the time. Our signage is all aimed at specific age ranges. I've been involved in the Facebook page. We've used the Facebook page for a number of things and a couple of competitions to get young people involved. Yeah, there's all sorts of stuff that I could talk for hours about, really. But yeah. We think, well, I think personally, from what I've heard from the community and wearing so many hats in the various communities that we have in Dunedin, I think we've got a pretty good service. However, there are always things that we can work on, and we take feedback as well. And so I meet with young people from the service and discuss how they felt about their interactions and what they have felt was maybe not so good and what they felt was really good and worked for them. And we acknowledge that everybody's different, so there's kind of a different focus and different service that you need to provide to each young person. But we celebrate young people in that they are different. Thank you.
Yesterday I was doing a clinic, as I do on Monday afternoons, at the Youth One Stop Shop in Christchurch. Talk more about that later. There was a 19-year-old who came with his mother. His mother had already talked to me, was desperate, really worried about her son, had kind of lost him for a couple of years. The son came in, sat down, highly intelligent. He knew exactly what he wanted. He knew just what he needed. He said, I've lost the last 2 years. I need to get back on track. I need some help doing it. Now, if I'd have done a quantitative SACS in terms of how much cannabis he was using, it wasn't actually very much. He was smoking spliffs, he was doing hookahs. He wasn't really doing that much. But in his view, his life, he'd lost for 2 years. And he was in danger of losing his partner. And he was working in retail. And when I said to him, what would you rather do? He didn't know. When I said to him, what do you think you've lost? He didn't know. When I said to him, what would you like to do? He didn't know. But the point was, he knew he wanted something. But he needed a lot of guidance. But he knew what he wanted. And that wasn't for me to tell him what he wanted. So that's what I want to start with. I better have the... And I'm wearing a visual aid. I don't really need PowerPoint. Because, as you see, this beautiful jersey has a red background. That's you. And as you see, there's multitudinous colours interwoven. That's all the things they need. Interwoven in one garment. Not really us saying, well, we'll do that bit, and you guys can do that bit, and well, yeah, those ones over there can do that bit. And youth, well, you just find out, will you? Because that doesn't really help. What are the differences between primary and secondary care? Well, in my view, and I must admit I didn't go and look at the literature, but I'm sure there's heaps of literature on this. In my view, the difference is in primary care you self-refer. In secondary care, you need a referral. So that's where it's interesting blurring with AOD stuff, because often people do self-refer to AOD and they don't need a referral. There's a difference in terms of cost. Secondary care service is usually free, primary care service is usually cost, except for the youth one-stop shops. It's about perception. Like Kelly said, I'm not bad enough to go to secondary care. I don't need that. I'm not really that bad. My 19-year-old thought that too. He didn't think he needed help because he wasn't that bad, but he did know he'd lost 2 years of his life. Secondary care tends to have finite end dates. You know, you're discharged now. I remember we had an audit once, and we said, and the audit said, "Where are your discharge plans?" And we said, age 25, because we didn't have age was our discharge plan, and the idea was that our discharge was hopefully when brain development had finished, and that those frontal lobe connections had been healthily made, and they were prepared for adult life. So what services do young people need? And where are these AOD and mental health services? And actually, I think that point's already been made. They're everywhere. But we need to kind of recognize them. If we can actually start to integrate them and talk to each other, I think that will be helpful for the young person. Because in my view, the young person's in the middle. And then their services need to be around them. And whānau is part of that. So we need to give them as much training and support as we do all our other service providers. And it seems to me you can find service in schools, you can find them in specialist services, you can find them in community, you can find them in primary, secondary, tertiary, wherever. But you shouldn't have to look that hard, and we have to look that hard at the moment. To me, it's the WHO 4 A's, and I think really Kelly summed them up very well. It's about accessibility. It's not just about having pool tables in the waiting room, but that does help. It's about accessibility in terms of transport, in terms of cost, in terms of can I find it, unlike the Youth Wind service, and is it available? And that means really not just is the transport there, but it really means is it available to me? Is there any gatekeeping going on? Is it something I can avail myself of really easily without having to think twice and getting loads of directions? And is it appropriate in terms of, is it an adult service that's actually just called a youth one, or is it really appropriate to my age, and not just my chronological age, but my developmental age? And is it affordable in terms of not just do I have to pay something when I get there, but is it affordable in terms of the scripts I might have? Is it affordable in terms of the cost of transport there? Is it affordable in terms of me affording the time? I asked a young man once, how come men don't go to services, young men don't go to services? And he said, well, look, you go there, they tell you what you already know, they don't give you what you actually really do want, you have to wait around for ages, and you'd really rather be doing something else in that time. Anybody else feel like that when they go to the doctors? So how can we make primary and secondary care a bit of a seamless garment like my lovely jersey? Well, it seems to me it's work on both sides. And it seems to me if we can make it into one side rather than two sides, wouldn't that be awesome? So let's telephone each other for advice. Really interesting. I really like Grant's continuum of service thing. And actually, when he looked at all the different aspects of comparing AOD youth with mental health youth, those are all the people we see. And I know it's all the people that all the youth one-stops around the country see. We see the same population, actually. GPs don't. GPs do hardly ever see young people, except for sore throats and twisted ankles. But we're trying to encourage them to look at every visit by a young person as an opportunity to do early intervention for their mental health. But how are they going to do that in 15 minutes? How is that going to be funded? Because they're private businesses. So maybe we can look at some simple stuff in terms of telephoning each other for advice. The other thing that the 19-year-old I saw yesterday taught me was, don't do to me. And I think sometimes primary care services feel like secondary care services do to them. We know best. We'll tell you what to do, because you don't really know much about this stuff. And some of us don't know much about this stuff, but actually some of us do. So let's do some telephoning advice mutually. we need to send good information. So when primary says, oh, I can't cope with this person anymore, I need some resources, which you lot have got, let's have good information going from the primary to the secondary, and vice versa, because secondary discharges them. They have an end date. So young people don't have an end date. They need ongoing care. Let's have really good information. And actually confidentiality is the only issue really is consent, it seems to me. And young people don't mind you sharing their information, but they do mind if you do it without their consent. Let's attend training and provide training. So that's mutual. You never learn anything unless you learn from each other. And let's discuss difficult cases. That's where I found it's really worked well. When secondary and primary have worked together on helping that young person. So it's not you'll do this and I'll do this. It's how can we together pitch our brains together to come up with some solutions with the young person so that they can actually do better. And hey, how about working in my work for a while? And how about primary people working in secondary works for a while? And that's where I love the AOD model in terms of they go out and work in everybody's work. And it seems to me that's really helpful, because not only is it helpful for the young person to access, it's helpful for the other workers, because then the other workers learn from each other. And the primary care workers from the secondary and vice versa. And that's always got to be beneficial. So what are the blocks? The ignorance of what's out there is number one. Funding's number two, in terms of the money needed to liaise, and that's been said already. The busyness, it's heads down, bums up, just surviving. Not having a co-pupper so that the team can work unhindered, and that common understanding is vital. So what can you do tomorrow? Well, I reckon you could go out, map out all the mental health and AOD services in your area. Where are they? And where do they interact with youth? Hold a meeting of representatives of all of them, so actually you all know what everybody's doing. Decide the cheapest and the easiest first, second, and third steps. So the first might be let's telephone each other more. And arrange a next meeting time. So it's not just a one-off meeting, it's ongoing. But the most important thing is have coffee. And the second most important thing is come to the Collaborative Hui on July the 9th, 10th, and 11th. Because 10th and 11th, we're talking about how can adults work together. Just what we're talking about today, but we're talking about it even wider, not just AOD and mental health. How can we work together better to better support young people and their well-being? And the first day for pre-Hui workshop is going to be, if you're interested in research into youth well-being, please come. I'm going to try and put together a framework for further research using all the different modalities of how people think about well-being. So to sum up, relationship, that's what it's all about. And if we can improve the relationships between us as adults who work together with young people, then I reckon young people will do much better. Thank you.
At the start of this session, Fraser gave us a mihi, told us who he was, where he's from. If you like, he demonstrated some core engagement skills if he was working with Māori and with others too. So I just want everybody to stand up who feel that they are able to give, it may not be as proficient, but certainly a mihi to somebody who came into you to see you, either a client or their whānau, or maybe even a colleague. So just stand up if you believe you can. Yeah. All right, so that's probably about less than half, or about half. That's good. Because one of the challenges for the next forum, I guess there'll be another forum, will be that everybody can do this. Because I guess for me, being responsive, certainly being responsive to Māori, is about engagement, and the engagement process often is about the sharing of who and where you're from, and there are various ways of doing that. And the message about this mihi and about engaging has been out there for ages, and yet still a number of us are still learning it. And I guess the challenge for us all is to get past the learning and move to doing. All right, so in case you didn't realise, I'm from Matua Raki, your National Addiction Workforce Program, and I'm to talk about responsiveness, and particularly, I guess, about Māori. One of the things that's happened today is that a lot of the things that have come up apply equally to Māori. And so some of what you'll see over the next wee while maybe repeat, but maybe it's about reminding you actually that it still applies, and that maybe that in that thinking about it, we might consider whether in fact it's the same. To get us to that place, there's a couple of things that also came up today. People have talked about collaboration today, and we've certainly done the case management, the change management kind of ideas floating around. One of the things about collaboration is just because we're working with youth doesn't necessarily mean that we're actually collaborating. So when we talk about collaborating with services, teams, etc., part of it actually is that we're on the same page, and perhaps even on the same page with the same song. So just because we're working in youth doesn't make us necessarily collaborators or necessarily working in the same way. And so part of getting past this is actually to have those conversations, form relationships, to get the idea of what our shared vision is. And certainly if we think about Māori responsiveness, and we're thinking about working with Māori community, Māori whānau, it's a bit like it's already been said, we can't make assumptions. So collaborating is more than just having an MOU. It actually does mean having a relationship. Once upon a time, we had leaders who led change. Nowadays, we seem to have lots of program managers, project managers who lead not so much change, but manage change. I guess part of the challenge for us and for you as leaders in the sector is to lead, not just manage. And what does that mean for you? What does that mean for you when you get out and have these relationships with people in primary care, with youth, with whānau, with iwi? So my challenge to you is to move past the theory of change management and actually look at what sits underneath that, because it's actually about winning hearts and minds in order to achieve those systems changes. All right, so let's go on to some of the questions that were actually asked of me to address. And while it was about responsiveness, I actually feel that responsiveness covers the kind of the breadth of things we've been asked to do. So, addressing CEP. And again, it's that reminder that while we've been talking about addiction services and mental health services, even with youth, there's still a large number who have coexisting problems. That mental health and some addictions going on, some addiction and some mental health's going on. But more importantly, I think what's come out today is that young people have a range of complexities, not just mental health and addiction, and they're all presenting at the same time, like Joseph's many-coloured coat, or coat of many colours. They're all kind of interwoven, and our ability to be able to look at the whole fabric, not just at the parts and threads, is a really important part of addressing CEP. Having welcoming, hopeful and complexity capable, it's got to be a kind of the big thing we're always trying to do. We've talked about welcoming. I guess I'm wondering how we'll make it hopeful, and what will that mean as we look at youth from different cultures and all sorts of other kind of contexts, social contexts. What does hope mean? And some of it will be, as I think as Sue said, what does hope mean for them? I think as we go forward, addressing the whole service and practitioner capability to work with whānau. So that's not just about family inclusive, where we kind of invite them to bring someone to the interview. And it's not just about family therapy, where we might actually say, move in and kind of create an atmosphere that will support the young person make some changes, or even support a family make changes. This is actually starting to work with whānau, starting to work with whakapapa. What does that mean? How is that different way of working? What will that mean for us as we start entering into this era of whānau ora and our whānau-centred practice? Because whānau-centred practice isn't just family inclusive or family-centred practice. What will that mean for us? And certainly for funders and planners to get our heads around the fact that they are different, and we can't just put them as a slash in a sentence and use them interchangeably. What will that actually mean for service design? Services and practitioners who can assess and understand cultural context. So if it's important to do assessment, part of it will be saying, for Māori responsiveness, what is the cultural context? It's not so much that they identify as Māori, that's going to be a really important one, because identity has been shown to be important for many Māori. It's also about how much do they participate? What in fact does the non-participation or the non-identification mean? So understanding how those things interact, not just as precipitating factors, but perhaps as protective factors. What does that actually mean? So having services and practitioners who can actually do that, and we talk about comprehensive assessment, what does that actually look like when we start looking at that cultural formulation? Māori is often really lowered, and if you listen to Mason's latest work, languishing. what do we do to lift the spirit, lift the Māori of people? So, part of, I guess, working with youth is how do you start to feel a spark of liveliness, of curiosity, of vitality again? Also for us as services and practitioners, understanding that when we're working particularly with substances like cannabis, your wairua is affected. So what does that mean for the way we work? What do I see when I look at your assessment? What do I see when I look at your case plan? What do I see when I look at what you're doing and the people that you're working with? If I can't see that any of those things have changed from now, then I've got to ask the question, are you really seeing wairua as part of the context of a young person's life? Or Māori even. So there's a need for us to be culturally responsive to not only what's in Te Ao Māori, but also to Māori ways of working. And that they're therapeutic ways of working, not just the engagement, a mihi and a karakia. Those actually have some function. They actually do have a therapeutic purpose. So how many of us actually understand those? And that's obviously growing our cultural competence. And for young people who may or may not be aware of how those operate, what will that mean with working with young people? And if it's a way that we see as part of a transformation, how do we start to, as one of those whānau ora outcomes is, to engage them in things Māori? It becomes one of those kind of bigger goals for us to achieve. So there's competence and there's responsiveness. I'm expecting that Māori practitioners, so those of you who are part of Māori services, I'm expecting that we're going to be excellent, competent practitioners. For other services, that's something to aspire to, but certainly I'd want you to be responsive. How will we know that? Okay, we look at primary care and specialist services, just that quick thing. Primary care, often for many Māori, are things like coaches, teachers, the kapahaka group. Those are where primary care often is the mates that do the research for one another and find out all the wrong things. That's often where many of the Māori who aren't coming to services are getting the information. How do we access that group? How do we see primary care not as necessarily a set service, but a setting, a frame of mind where people gather, talk, and think. And young people are quite savvy around that, and where they can go. And then hopefully they'll lead on to the one-stop shops that Sue talks about. But they have to be seen as part of the process. And certainly if we start thinking about how we make linkages and networking in those kind of settings, what will that mean for our own competencies for that liaison role? Youth-friendly. What does youth-friendly mean for working with Māori? And my big thanks to Te Hina Manaki Tanga Trust for donating me some of these images. And again, I want to thank people who are part of the Pouwhakahaere network who have also given me some of the ideas for this presentation. So, for many of the youth, and certainly in that holiday program, and for many Māori youth, the access point has been about them coming to do activities, wakaama, coming to learn and do music, coming to do rap, I suppose that's music, coming to do graffiti, legal graffiti, not on the doors at night or something, but those artistry things, learning to dance, those are the things that draw them in. And in those spaces, it's not the lecture, but the opportunity to explore what might be going on, that they then would have a chat somewhere else. Some of those are the things that are drawing people in and becoming more than just the waiting room stuff, but rather the things that they can feel safe in. And I guess that's the whole thing. Again, it's about the communication is the message received by them, rather than the one that we're sending. What's the message that they're getting from us? And us being able to check back. What were you hearing in that message? What were you hearing in that pānui? What were you seeing in those web pages or those Facebook pages we're putting out? Because what we think we're sending may not necessarily be what they're getting. Cultural responsiveness, which is where I'm supposed to have started. But as you see, cultural responsiveness has to be all the way through. We have to be thinking what's going to be different. Anna, before lunch, talked about the kind of prevalence, talked about the presentation rates of Māori. So, if they're not turning up to our services, then that's obviously an issue for us. If they are turning up to our services, what are we doing that's going to be different? The other thing is the stuff that's coming out today is not new. We put out the framework for alcohol and drug services in 2000. It said much of what we've been saying today. Jury talked about the whole need to integrate cultural and clinical factors into, in this case it was about conduct disorder. But again, it's not a new idea. in that also we're looking at across a whole range of things. Primary care, if you like, is the education, it's the sport, it's the driving, it's the relationship, it's all those complexities. So these messages aren't new, so I guess I'm wondering, after 10 years, or nearly 10 years, why have we not seemed to have advanced so far? Another thing for us in terms of relationship or in terms of responsiveness is, what does Māori mean? And so for some Māori, that's actually the thing that holds them together, and they have a really active participation. So while they may look slovenly and not do anything, in fact they may lead actually quite vital roles within their whānau, within their hapu, within their iwi. How do we check that out? That's a protective factor that we should be exploiting. Also, we talked about primary care as a place of resilience, if we're thinking about secondary prevention, and a place of messaging and a place of modelling. And in this sense, it could be that we make use of those things like kapahaka, like Donna. So the regionals are coming up. What, 10,000 odd people taking part on the stage? Well, no, maybe not a couple of thousand.
Yes, it's quite large in Tarawā and Rotorua, so it covers right across the Tarawā region, which is from Matua right through to Werry.
So a couple of thousand people on stage? Yep. And behind them is... Yep, and so behind them there's another whole bunch of people. So you're starting to get 10,000 odd people being mobilised around a healthy activity. I mean, where do we and how do we use those kind of those forces? So many of our people may be inaccessible, but they're actually in places like that. And so how do our young people see themselves, and young Māori in particularly? One of the things is that we see a lot of Māori who are blended now, more and more blends. So what does that mean? So even though they might feel comfortable with a Māori approach, they're still in a blended place. How do we also respond to that? And I guess even for Māori practitioners, it's how do we ensure that we're not being culturally unsafe? How do we ensure that we are actually responsive to Māori youth as well? Practitioners who are competent. So one of the key things for Māori responsiveness is that Māori services and Māori practitioners are competent Te Ao Māori and in Māori therapeutic models and practice. For non-Māori, it's about ensuring that they're also responsive. Okay, so what does a good service feel like? Because I don't think it's a look like, because you can all tick boxes to say you look really good, and I think somebody mentioned that earlier on. You can all have all these processes and have everything down to the contract, and nobody comes to you. Why is that? Because maybe the feel's not there. So what would be the feel that actually young people, when they get the feedback, you get feedback, feel welcome. They feel that it's hopeful, and that you are dealing with the complexity of stuff, not just one issue. Some of the suggestions that have come up is that actually in the future CEP practice should be situated with providers who provide social services rather than mental health services. Of course, in that setting too, you'd be providing mental health. But they're saying move away from this idea of just mental health and addiction. Move out, move beyond. And of course, getting our heads around whānau order will be part of moving from our, languishing to our flourishing whānau. But watch this space, you'll hear more about that coming up. Yep. A service would feel like it's got manaaki, whakawhanaunga, so you'd actually see the linking, you'd see relationships happening externally as well as internally. You'd have nāko mahaki, the things you would feel. And of course, you'd feel the spirit being lifted, not only with your staff, but also with the people you work with. I think we've said that today, there's more training, including cultural training. Resources are skewed, and I guess part of the also skewing is if Māori present in such big numbers, if we did the financial thing, why isn't more money necessarily going across to those services to be better? One of the things I think is a barrier is that many of us, or many of you, are unbelievers in the power of Māori to make difference in the lives of people. And that many of you will accept the tick box ritual stuff as part of Māori being Māori responsive, rather than necessarily thinking about actually Māori therapeutic practice. So magic wand stuff, social services, competencies, whare o tiki is really biggie, and culturally competent staff and services. At the end of the day, I think this is really, and supervision, of course. It's already been said, this is a Henry Ford pickup. but it's still, if we always do, we'll still be here in 20 years. But here's our thing, I guess. I asked my boy, who are the kind of models out there still? And he says, Tupac, oh yeah, and Bob Marley. And I'm going, these fellas were long gone before you were even born, but they're still big, and he's not even, but anyway. This is the thing I think the challenge for you as funders and planners, as service providers, as managers, emancipate yourselves from mental slavery. And I guess the mental slavery I'm thinking about is being stuck in the models that we've been in. You've got to actually emancipate yourself. But only you can do that, because on paper, you look good. On paper, we make it look good. But really, are you leaders or are you project leaders, project managers? I guess that's the big challenge that I put out for us today. So, kia ora tātou.
I'm just going to talk about CEP from a mental health point of view, and specifically from the point of view of an AOD service who is youth AOD service. We're working with young people with alcohol and drug. We know the principles of CEP and of good youth care is that we don't send the young person off to other services to get every little bit of them treated by a different kind of place. So how do we do that ourselves within a youth AOD service with maybe limited sort of training and expertise in that area? So just this is discussion points around that, I guess, and in no particular order, and they're not particularly related. So the first point is about recognition, and I think we talk about having screening instruments and as tools to kind of help us recognise CEP or mental health problems in our young people who might present with AOD problems. But the reality is this isn't enough, and I think as services we need to be on the lookout for clinician blind spots. I think there's certain clinicians that we'll work with who don't see the CEP or their depression and anxiety in the boys that they are seeing, for example. That just doesn't enter their thinking, and you can train them, but you know they don't see that, and so I think we need to be aware as service leaders of the strengths and weaknesses around this in individuals and services, and we need to sort of make not allowances, but we need to address that through things like using an MDT team effectively, etc. Okay, so the first point was recognition. Second point is just about autistic spectrum disorder and fetal alcohol spectrum disorder. And no easy answers here, but I guess I was at the sector meeting the other day for CAMS, and hope is sort of on the horizon, in that it seems that one of the difficulties that we have providing care in this area around autistic spectrum disorder is the disconnect between disability services and mental health services, and particularly around funding. But it would seem that is being looked at the moment and being addressed, and I was reassured, I brought this up, but I was reassured that the systems that will be looked at around the problem that youth and adult services have around, you know, getting effective care for people with autistic spectrum disorder, once they're sorted out, similar kind of thing might be able to be looked at in terms of fetal alcohol spectrum disorder. So we're talking about these young people who have cognitive difficulties, but they don't necessarily have low IQ, and disability services tend to be, you know, there's cut-offs in terms of IQ. So that was point 2. Point 3, conduct disorder. And just as a discussion point, is how well is this label or this disorder serving young people? And I think there's potential that it could serve them well in terms of services and treatments and things, but up to this point I think it's failed our young people, and it's just become an excuse for too hard basket, or we can't do anything about that and stuff like that. So you know, this is a discussion topic for a whole day's meeting, but I just thought I'd put out there. Next, the next point is about modularised treatment, and Tanya will be able to answer questions about this, hopefully better than myself. But the Werry Centre are currently, I think it's called the Tracy Project. Tracy Project, and it's looking at testing match treatment, and match treatment is a system of a modularised system of treatments, and they're testing it in CAMS teams, and essentially the team is trained up in a whole lot of sort of brief modularised kind of interventions, and then as young people come in, the clinicians who have access to a range of maybe 20 or so different kind of things that they can do for different disorders are able to discuss it with the young people and together work out what are the best kind of modules, if you like, for that young person's treatment. Is that fair, kind of? No, we're not involved. Yeah. You know, yeah. So the point being, I think for alcohol and drug services, for youth AOD services, this is the kind of thing that we'll be able to hopefully tap in for our and for AOD clinicians in terms of having interventions and things that they can do to address CEP in their clients. Yeah. So watch this space. Another point, detoxification. How big a part does it play in the care that you are able to provide for your young people, and what, and more to the point, what do you need for that, and what's available in the community, and how in terms of other services, and how can resources such as respite facilities or the doctor who sits in CAD's unit over here, who has detoxification expertise, how can you pull those in and utilise them so that young people have good kind of care around that? I'll just do a couple more, I won't do all 10, but DBT, mindfulness and skills training. Again, this is for an alcohol and other youth AOD service. These are skills groups, and skills training are the kind of things that an alcohol and drug clinician who may not necessarily be trained as a psychologist or whatever, but will be able to attend training and learn how to do this and apply it to the CEP problems, particularly mental health and emotion regulation kind of difficulties that our young people have. And there's really good applications. When you think about DBT, is initially is developed for self-harming young people and adults, and self-harm is substance use to some extent, and some of our people is just another way they regulate their emotions. So the self-harmer will self-harm, but the substance user will impulsively go off and use or whatever. And so many of the principles can be transferred to our population, and so this will be another kind of area that hopefully develops over the next few years. But what we do need is DBT for boys, because we're looking at it in our service and how we can apply it, and it's it doesn't work for young, well, it doesn't apply, and it doesn't seem to resonate with young boys so much, but we're sure that there are kind of other ways the same principles can be conveyed in a way that is more, that young men are more receptive to. And lastly, Sparks. So e-therapy. So Sparks was launched yesterday by the Prime Minister in Auckland University. And if you go to www.sparks.org.nz, there is a world-class, effective CBT intervention there for anxiety and depression, and also just not coping kind of stuff. It's as good as sending someone to a to a CAM service and getting usual care from them. So this kind of thing is going to just revolutionise the care and the CP kind of care that we can provide in a youth AOD service. And what we're going to be doing in CADS Old High over the later this year is we're going to be evaluating usual CADS Old High care with usual care plus getting the young person to do the Sparks CBT, computerised CBT course. And what we're going to, I think how we're going to do it is we're just going to cut down usual care. So instead of sort of 40, 50 minutes, it's going to sort of be a 25-minute AOD thing, and then a 20 minutes on the computer doing the Sparks kind of care. And we're going to evaluate sort of things like how young people respond to it, and if they like it, and if they stay in care longer, and if they improve. Yeah. So we're evaluating that now, but there's no reason why you wouldn't just do it straight away, and certainly refer young people to it, because it's free online.